uh, I would like to thank Remedy team for giving me this opportunity. Today we'll be discussing about invasive fungal infections. So as you know, we have been going through clinical scenarios and situations and discussing the practical aspects. How do we deal day-to-day challenges in the ICU? So to have an overview of this talk, invasive fungal infection, it is known to increase the mortality and morbidity of critically ill patients. The mortality increases by 40 to 90%. CDC has reported a crude mortality of more than 25% in patients with candidemia. In patients with candidemia, the mortality increases by 25%. And patients who have invasive aspergillosis, the mortality is 40 to 90%. So that is the seriousness of the situations that we are talking about. And any invasive fungal infection increases the cost to the patient, the financial burden to the patient and the society increases. And this is more so, especially in patients with who are immunocompromised. We'll see the further how which all patients are at risk, how we need to mitigate this risk, take into considerations all these factors while dictating treatment for these patients. So let us discuss a clinical case. I have summarized the clinical case. I have put it in one slide so that we'll concentrate more on discussion of invasive fungal infections. Whatever I will be discussing today will be from 2016 IDSA fungal infections guidelines. No further guidelines have come through IDSA after 2016 guidelines. The other paper I will be referring to will be ISSCM position statements. This was published in 2024, last year. ISSCM published position statements in patients with immunocompetent patients with fungal infections. So they do not talk about immunocompromised, but it's more or less the same aspects we have to consider. So we'll go in with this clinical case. Here we have a 43-year-old male. He had features of abdominal pain, vomiting, severe abdominal pain. He is an alcoholic. So on evaluation, he was found to have acute severe pancreatitis. So I'll not be going in depth of pancreatitis. He was managed conservatively as per the clinical guidelines for the management of acute severe pancreatitis. So he was initially managed with fluids and paracetamol, pain relief, and nutrition was started, and then patient tolerated. He was shifted to ward. On day 9, patient had shock. He was brought back to ICU. CT was done. You can see the CT, which shows features of necrosis. CT showed features of necrosis. So CT guided aspiration was done, which showed Klebsiella pneumonia infection. So necessity targeted antibiotics was given, patient stabilized, and the patient was shifted to ward. On day 16, patient became tachypnic. He was looking toxic, he had shock, and he was shifted back to ICU. Now, what is the thing that should be running in your mind? Anybody can tell anything about it at this juncture? What is the important thing that should be running in your mind when such a situation happens? It usually happens in your day-to-day practice. Can anybody answer? So, yeah.
Suboptimal treatment.
Yeah, one thing
Suboptimal treatment.
we should look is patient is already on high broad spectrum antibiotics. So whether any invasive fungal infections, we have to have it in your mind. So with the background of this, we'll go with the discussion on fungal infections. So how do we classify fungi? So based on the morphology classification of, this is a morphological classification of fungi. Fungi have been divided into yeast, molds, and dimorphic. So yeasts are unicellular fungi. Molds are multicellular and dimorphic, which appear in both forms depending on the temperature and the way they express themselves. So there is a lot of microbiological data involved in what temperature, how do we culture, and all those things. So yeast can be true yeast cell. For example, for it is a Cryptococcus, which is a single unicellular that is a true yeast. Pseudohyphae is these are elongated cells which on microscope can appear like a hyphae. So example is Candida. Molds are aseptate hyphae. Examples are Rhizopus, Mucor. Septate hyphae where there is definite septae is there. Examples Penicillium, Trichophyton, Microsporum. These are the septate hyphae. Dimorphic hyphae, they appear as yeast forms, that is a parasitic form which can be cultured at 37 degrees Celsius. Examples blastomycosis, histoplasmosis, histoplasma and spore and filamentous form or mold form, saprophytic culture which can be cultured at 22 to 25 degrees Celsius. So coming to epidemiology, candidemia, it is the most common fungal infection in ICU. So most common fungal infection that we encounter in ICU is candidemia. Candida is divided into Candida albicans and Candida non-albicans. Earlier, it used to be albicans infection used to be the predominant infection. Nowadays, it is non-albicans infection. Non-albicans have taken over because of routine, many reasons we'll be discussing subsequently. Routine use of antifungals. So that is also a contributing factor for non-albicans Candida. The incidence is around 6.5 cases per 1,000 ICU admissions. So if you have 1,000 ICU admissions, the incidence is around 6.5. It may be higher, but this is what the statistics say.
ಆನ್ ಮಾಡಿದ್ದೀನಿ ಇನ್ನು
Candidemia, the median age stay of 8 days in ICU. Usually, patients can develop candidemia, especially in patients with invasive catheters. In the, I told you, non-albicans Candida is the most common. Candida auris, it is the commonest and it has got a significant potential to become resistant to routine drugs. So multi-drug potential is more common with Candida auris. So that is why it is also called as superbug. It is followed by Candida tropicalis and Candida parapsolosis. Coming to what are the risk factors that these patients in ICU can have, who can develop Candida. So patients with urinary catheterizations, indwelling catheters, CVC insertions, see, more number of CVC days, patients on endotracheal tube, tracheostomy tube, invasive mechanical ventilation, patients with total parenteral nutrition, patients with renal failure, more so with patients on dialysis, more so with peritoneal dialysis. And the more the patient stays in ICU, more is the chances that the patient can get Candida infection. Patients on immunomodulators or immunosuppressants therapy. Most common immunosuppression drug that the patient is on is steroids. So steroid therapy increases the chances of Candida infections in the ICU. What are the risk factors for patients developing invasive aspergillosis? Patients with COPD, they can get colonized with Aspergilla. Patients with liver disease who have deficiency of immune system to fight infections, they're at risk of as such fungal infections, more so with invasive aspergillosis. Cirrhotic patients, lack of HEPA filters in the ICU that predisposes for aspergillosis, prolonged ICU stay, exposures to corticosteroids, diabetes, coronary artery disease, trauma, patients with multi-organ failure. All these increase the risk for invasive aspergillosis. So the mortality, as I told you earlier, it can go from 40 to 90% if the patient develops invasive aspergillosis. So most common species are Aspergillus flavus and Aspergillus fumigatus. These are the most common species. So you can do ball if the patient is intubated, or even if it is not intubated, you can do a ball, and you can go and do a serological test. You can send ball also for galactomin. Galactomin index value more than 1 helps in invasive aspergillosis. Next is invasive mucormycosis. This we saw more so during COVID pandemic. So risk factors include sicker the patients with high aperture 2, patients who are on ventilator, patients who are on dialysis, patients who are on being used steroids. We saw patients with diabetes steroids with COVID. They invariably develop black fungus. So the even general public were aware of black fungus those days. Uncontrolled diabetes, hematological malignancy, and solid organ transplants. Patients with hematological malignancy will have severe depression of immune system. So they will be at risk of all kinds of invasive fungal infections, more so than solid or patients with solid organ transplant recipients. So what are the practice points that are important to us? In a patient who is non-neutropenic, in a non-neutropenic patients, as we discussed earlier, non-albicans candida is the major fungal pathogen. So in that Candida krusei is azole and amphotericin B resistant most of the times, and it can be treated only with echinocandins. That point we have to remember. Candida krusei, if you do speciation, we have to start them on echinocandins. Candida auris, as we discussed earlier, it is at risk of developing multi-drug resistance. And whenever we put the patient on azole therapy, azoles are known to have a lot of drug to drug interactions. So we need to, if we're putting for a longer duration, we need to do a therapeutic drug monitoring.
அது ஃப்ரீக்வெண்ட் அந்த அப்பாவோட பையன் கிட்ட ஐ மீன் அந்த பேஷண்ட் பையன் பேஷண்ட் ஃபாதர் அவர்கிட்ட பேசினேன் நான் கேட்டேன்.
Thank you. Patients in a neutropenic patients with AML, ALL, or hematopoietic stem cell transplant patients, aspergillosis is the commonest and it has got high mortality. In India, it's being reported in more patients with COPD, liver failure, cirrhosis, as we discussed earlier. So, whenever we suspect patients with invasive fungal infections, the diagnosis is a problem. It is not as simple as we diagnose a bacterial infections. There is lack of confirmatory tests, and the tests usually take longer time. And many places like Mysore, we don't have VDG or galactomin done here only. So usually it will be outsourced to either Bangalore or Mumbai, and the turnaround time is usually 3 to 1 week, 3 days to 1 week. So that takes away a lot of time. So, and the clinical features also, we have to have a background high index of suspicion. Then only we can pick these patients. Radiologically, we can diagnose, but not all fungal infections can be diagnosed radiologically. There are biochemical markers which we will be discussing today, and direct identification is the confirmatory test. So how do we identify? Culture is the gold standard therapy, gold standard diagnostic tools, not therapy, sorry. Culture is the gold standard diagnostic tool. The advantage is we can speciate, we can do sensitivity testing, but it takes time. The turnaround time is very high. So most of the patients, usually they release sensitivity every week. So usually we wait for 1 month for the full report to come. And the culture yield is only 30 to 50% only. And sometimes we pick up colonizers. So, and it is more so in patients with invasive aspergillosis to culture and identify and treat. So, but this is the gold standard. Then we have molecular diagnostics, depending on what they express and the identification of DNA. T2 Candida we can identify by DNA amplification, but it is very expensive. It is still not available in India, but it has got a quick turnaround time. MALDI-TOF MS, if the patient has a culture and if it is growing something, then we can do a MALDI-TOF. It identifies the organism faster. The advantage is it can even do tell us speciation. Then we have multiplex PCR and biofire, which can be used. Serological tests, the most commonly done is beta D glucan, BDG we call it. It detects 1,3 beta D glucan, which is a component of fungal cell wall. The cutoff value is around 80 picograms per ml. It is a non-specific pan-fungal biomarker. So we have to remember that it is non-specific and it is expressed by most of the fungal species. So it is a pan-fungal biomarker. It detects all kinds of fungal infections, including Candida, Aspergillus, except Cryptococcus and Mucorales. So except this, it detects most of the times. So it has got false positivity. It can, especially in patients who are on beta-lactam inhibitors and multiple drugs, multiple conditions can cause false positivity and high negative predictive value. If the patient has, if you do a BDG and if the BDG comes negative, it is like D-dimer. You can exclude fungal infections. But if it is positive, it can be false positive. It can be expressed in various kinds of fungal infections that we should know. Manan antigen and anti-Manan antibodies. These are specific to Candida species. So it is more specific and less sensitive than BDG. So you can do this Manan antigen and antibodies, anti-Manan antibodies along with BDG. So BDG tells us it is fungal infection, and if it is Manan antigen and antibodies are positive, it tells us it is candidal infection. So next we have galactomannan. So galactomannan is a heteropolysaccharide. It is a heteropolysaccharide which is present in Aspergillus cell wall. So it is specific for aspergillosis. So it can be done in all fluids except urine and CSF. Urine and CSF it cannot be done. So it also can cause false negative results. So neutropenics with lung infiltrates we can do. And if you can do a ball, galactomannan is more specific, sensitive in ball than serum in diagnosing aspergillus infections. So PCR based, as I told you earlier, it is rapid, it is fast, it can have high turnaround time. Nowadays we are using this. So it detects nucleic acids and amplifies and tells us which is the organism. But the problem is there are various methods of doing PCR, multiplex PCRs, biofire, so many things are there, and there is no standardization. So it cannot be completely relied, and there is no data or guidelines which says that this is the way to identify. So aspergillosis is much better identified in PCR based studies. In patients who are suspected to have invasive mold infections, if biomarker tests are negative, suspect mucormycosis. So if all the biomarkers are negative, you can suspect mucorrelated related infections. Then the other test is radiology. Some of the radiology has helped to identify fungal infections. So CT chest, if we have nodules, areas of consolidation, cavitatory lesions, localized bronchiectasis, tree in bud lesions, all these help us to identify if there is any fungal infection, which can point towards a fungal infection. Neutropenic patients may have halo sign, that is a nodule surrounded by ground glass shadows, or air crescent sign. In patients with invasive mold infections, mucormycosis and all, sinus and brain CT can be done to screen for mucormycosis, and it can be identified, picked up earlier. And we can take a biopsy and see them directly under the microscope. So these are the radiological pictures. You can see a dense nodule with the ground glassing. This is halo sign. Here you can see the tracheobronchial tree, which is looking like a tree bud appearance. So you can see tree bud appearance. Here you can see a fungal ball with a thin rim of air. This is called as crescentric sign. So you can see a air appearing as a crescentric sign is positive. These tell us indirectly that patient might be having fungal infections. So we discussed how when do we suspect invasive fungal infections. We discussed how do we diagnose. Then we have to come to treatment. So from the treatment point of view, we can start prophylactic treatment is indicated in some of the patients. In patients, high risk patient populations, we discussed what are all the patients high risk for what infections we have discussed. So in high risk patients to prevent invasive fungal infections, so we can use prophylaxis. It minimizes the emergence of invasive fungal infections. In critically ill non-neutropenic patients, anti-candida prophylaxis is recommended only in patients with secondary or tertiary peritonitis, repeated gut perforation, patients on TPN, anastomotic leakage. Then only we have to give prophylaxis. Usually used drugs are azoles, fluconazole, posaconazole, but azoles have a lot of drug interactions. We have to do therapeutic drug monitoring. Preventive use of antifungals. When we use preventive, it can delay initiation of, whenever we know delaying initiation of antifungal therapy is associated with higher mortality, especially in patients with high risk patients who are biomarkers positive and radiological suspicion is there. If the patient is high risk, if there are biomarkers positive and radiological suspicion is there, we have to initiate therapy. This is called as preemptive therapy because delaying initiation of antifungal therapy is associated with high mortality. We have to initiate therapy at the earliest. Next is the empiric therapy. When we have a clinical suspicion, but there is no confirmed microbiological evidence, there is strong suspicion is there is no confirmed microbiological evidence. Patients will be presenting with refractory fever despite appropriate antibiotic therapy. Our patient falls into this group. Is increasing respiratory insufficiency, need for ventilatory support, where prompt intervention is needed. Patient is in shock, is tachypneic, is going to respiratory failure. So we have to start them on empiric therapy and then confirm your diagnosis. Then we can use Candida score or Ostrowski-Zichner's rule. Ostrowski-Zichner's rule. We'll see what it is. So this is the Candida score. It can be used clinically to identify patients at risk of candidal infections. So there are 5 scores you can score. If the patient has clinical sepsis, and if the patient is on, that is 2 points. If the patient is on TPN, 1 point, patient has undergone surgery, 1 point, patient on multifocal colonization. Multifocal colonization means Canada identified in 2 non-continuous sites. For example, patient might have identified Candida in the lung specimen or in the wound somewhere in the gluteal, something like that. There should not be continuity of the sites. So if the Candida score is more than 2.5, patient is at risk of candidemia. The other one is this is Ostrowski-Hessner's score. Any systemic antibiotic or presence of central venous catheter, this has to be there, and at least 2 of the following: TPN for 1 to 3 days, any dialysis previous 1 to 3 days, any major surgeries 0 to 7 days, pancreatitis 0 to 7 days of pancreatitis treatment, any use of steroids 3 to 7 days of steroid therapy or immunosuppressive therapy. So if they are there, then the patient is at risk of candida infections. This is how we can clinically identify patients at risk of candida infections and give treatment empirically. So then we can send patients either blood or tracheal cultures for PCR based identification. But the problem with the trachea the lungs can be a colonizer for candida. So most of the times, the candida, if it comes positive in tracheal PCR, it can be a commensal. So we have to know whether it is infection only, then only we have to treat. Usually in the lungs, we look for aspergillosis, and presence of candida is normal or commensal. So treatment is we have to target antifungal initiation. It's once we have a positive blood or tissue culture, or we have to using antifungal drugs based on susceptible testing. So when we have susceptibility testing, we can target exact drug and control the infections. So targeted strategies encompass the use of various antifungal classes with adjustments based on patient's response and adverse effects. The duration and intensity of treatment should be tailored to the patient. So coming to antifungal therapy, so we have three major classes of antifungal therapy. One is azoles, polyenes, and echinocandins. So depending on the site they act, and so if the antifungal therapy targets the cell wall or cell membrane, it can be inhibiting ergosterol inhibitors. So in the ergosterol inhibitors, you have azoles, which are routinely used, fluconazole, posaconazole, isoconazole, polyenes, amphotericin B. Amphotericin B is the gold standard treatment to which all other antifungal therapy has been compared. And then you have beta-D glucan synthase inhibitors. In that, the main thing is echinocandins. Now the recent drug, one more drug is coming up, Ibrexafungerb, very difficult to pronounce. So this is still not available for clinical use. Then the intracellular targets, we have griseofulvin, flucytosine, all these other antifungal medications. So you need to know the classification and where these drugs act. So echinocandins, our echinocandins will be acting on beta glucan synthase inhibitor, whereas azoles and polyenes, you can see they act on the cell wall and cell membranes. So coming to invasive candidiasis, usually the source is indwelling catheters. So or pus or intraabdominal collections. So we need to do a source control wherever feasible. Like any other sepsis, fungal infections, you have to do a source control. If there is a mucormycosis, you have to aggressively debride the area, reduce the fungal load. That will improve the outcome. We have to concentrate on source control. Our initial therapy is echinocandins. For all, whether immunocompetent or immunocompromised, the initial therapy is echinocandins. Then you can give liposomal amphotericin B. Among the echinocandins, what are all we have options? We have most commonly used is casofungin. The bolus dose is 70 mg and 50 mg OD. The main contraindication for casofungin is severe liver dysfunction. Then we have mecafungin. Then we have anidulafungin. Micafungin and anilofungin do not have any contraindication as such, especially anidulafungin. You can use it in even in severe liver dysfunction. But the drawback is we have to give initial loading dose of 200 mg, then 100 mg OD. So liposomal amphotericin B is available in three forms. One is ionized form. Then the other one is bind to lipid complex. Another one is liposomal. The liposomal is it is more renal safe and but it is more costly, whereas lipid bound is little less renal toxic compared to the conventional amphotericin B, but it is less costly compared to liposomal and amphotericin B. So these are all the amphotericin B preparations that are available in the market. We can clinically use, and we need to know. Conventional amphotericin B, the dose is 0.3 to 1 mg per kg body weight, whereas liposomal amphotericin B is 3 to 5 mg per kg body weight. So the duration of therapy is, we have to repeat the culture every 3 days, and then once the culture becomes negative, from there 14 days, 2 weeks from the negative culture is the duration of therapy for invasive candidiasis. So you can use fluconazole in stable patients, especially for stepping down, if the patient is sensitive to fluconazole. Once we do the sensitivity, we can step down. Invasive aspergillosis, we have to alter the immunosuppressants. Most of the times patients will be on immunomodulators. Reduce the immunosuppressant suppression need, tailored to the patient, weigh the risk and benefit ratio, surgical source control if feasible. We have to give the drug of choice for invasive aspergillosis is voriconazole. You can give voriconazole, isoconazole, or posaconazole. If you are using IV voriconazole, it has IV cyclodextrin, which can cause nephrotoxicity. 6 to 12 weeks of therapy is indicated. As I told you earlier, azoles will have a lot of drug interactions. You have to do therapeutic drug monitoring. Galactamin levels can be used to stop therapy if the galactamin becomes negative. So that can be used. In a patient with mucormycosis, we have to do aggressive surgical debridement. Liposomal amphotericin B can be used. Till clinical improvement and radiological resolution is there, we have to continue liposomal antibody amphotericin B. You can change over to posaconazole, either IV or oral isoconazole once the sensitivity is available. It can be used for 2 to 6 weeks after amphotericin B therapy. Cryptococcus, we have to use amphotericin B because the penetration of amphotericin B in the CSF is limited. It is not as good as in the other tissues. So you have to combine with flucytosine. You can use a combination with the fluconazole as well. We have to use induction phase of 2 weeks and consolidation phase for 8 weeks. So PCP pneumonia, cotrimoxazole is the treatment of choice. With any severity, we have to use adjunctive glucocorticosteroids for 21 days, 5 to 20 mg per kg of trimethoprim. So once the patient improved, after 2 weeks of negative culture, we stopped casofungin. So we need to suspect what is to conclude from this case is we have to have a high index of suspicion for invasive fungal infections. Whenever there is a high index of suspicions, patients at risk, then only we can identify and think, and we need to assess the risk. And these invasive fungal infections will have diagnostic dilemma. So whenever possible, we need to do a source control. Prompt initiation of antifungal therapy is the key to success in such patients. So any questions? Am I audible?
Yes, yes, you are audible, Dr. Madhav.
Yeah, Dr. Raghunath, welcome. Anything we have missed? You want to add on anything?
No, I'm sorry, I was a bit late. I was busy with some other case actually.
Okay.
I came just now, just 5 minutes back.
Okay.
I think any scholarship.
Any questions from the participants? We're happy to answer. Me and Dr. Raghunath are here. So, Salma, any questions? What is the take-home message in this class? Salma is there?
Yes, sir.
Anybody? Salma, what is the take-home message? Do you have any questions for us? Did you follow the class? Did you have any difficulty?
Hi, sir. No, sir. We discussed about different type of fungal infections, including both multicellular and immunocompromised and critically ill patient, and what are the drugs to be given on each situation.
Okay.
Yeah, it is very
Dr.
difficult
Sundram,
to.
Dr. Sundram.
Hello. Hello.
Hello, sir.
Sundram? Yeah, I can hear you. Dr. Sundaram is there? Anybody else? Any questions?
Sir, yes, sir, I'm there. Sir.
Yes, sir.
Okay.
Sir, actually, right at present, I'm in OT, so less exposure to critical care cases. But
Okay.
previously, when I have experiences like whenever antibiotics, if it is not giving a typical expected cure to the patient, and then only we will be thinking of antifungal, I mean, fungus causing the issue. We are more thinking about bacterial infection when compared to fungal infection. And practical issues come when we encounter patients with moderate liver dysfunction, whether to start fluconazole empirically or not. I have encountered such issues previously, sir. So I usually, while discussing about antifungal, we will have problems in explaining attenders, sir, about whether we can go ahead, whether we have to wait for a culture report and then only start. But those are the
As
issues
we
I face.
discussed, fungal infection, the diagnosis, it is a challenge. So we
Challenge.
have to have a high index of suspicion, especially patients in ICU, prolonged ICU stay on
Yes, sir.
multiple antibiotics and broad spectrum antibiotics. They are at risk of patients on steroids, diabetes, multi-organ involvement. They are at risk of invasive fungal infections. And you have to review our catheters, whether catheters can come out. And you have to start therapy at the earliest for a better outcome.
Yes, so that's why without a senior person's help, it is a bit difficult for beginners to start antifungal. That's what I feel, sir.
Yeah.
And that's it, sir, from my side.
Okay. So if nothing else, then we can wind up the class.
Thank you.
Thank you, Dr. Raghunath.
Salma, please.
Yes, sir. Thank you. Thank you, sir, for sharing such valuable insights on this topic. We sincerely appreciate for the time taken to share this knowledge and expertise with us. Thank you, everyone, for joining today's webinar. We truly appreciate your time and participation. Thank you all.
Thank you.
Thank you. And good night.